No problem. It's a good number for a beginning. Then people will have next 5 minutes.
Good evening, everyone. And yes, today the VAA ISA Ballari Group invites you all for the Silver Jubilee, that is the 25th monthly academic program. So we have today's topic by Dr. Balavenkat sir about the anesthesia for major spine surgeries. And initially we'll have the welcome address to the program by Dr. Srinivaslu, who is a past President ISA Karnataka and is the current HOD of WIMS Ballari. And this is followed by introduction of the speaker, that is Dr. Balavenkatasubramanian sir, by Dr. S.S. Harsu sir, who has served as a past President ISA National and also past Editor-in-Chief IJA. He has previously served as the HOD of WIMS and BMCRA and currently working as a HOD at Ambedkar Medical College, Bangalore. We also have Dr. Gurudat CL sir, who is the past HOD and at MMCRI and also JSS Mysore Medical College. And he has previously served as a professor at our own institute, that is WIMS Ballari. He shall be coordinating the question and answer session. So now I invite Dr. Srinivaslu sir to welcome all the delegates and the participants. Over to you, Srinivaslu sir.
Very good evening all. On behalf of Indian Society of Anesthesiologists Ballari Chapter, WIMS Anesthesia Alumni Group and the Department of Anesthesiology, WIMS Ballari, I extend a warm welcome to all of you. Today we have a lecture by Dr. Balavenkatasubramanian. He is ex-GC member and consultant at Ganga Hospital. And in spite of his busy schedule, he has accepted our invitation. First of all, thank you, sir, for accepting our invitation and welcome. Next, I welcome Dr. S.S. Harsu, sir, who has worked as professor and HOD in our department, then at BMCRA, then he was Director of Medical Education, Karnataka State, and he was as a editor and president of Indian Society of Anesthesiologists National. I welcome you, sir. Next, I welcome Dr. Gurudat sir. He was also has worked as professor for a long time in our department, and then he has worked as professor and HOD at MMCRI Mysore. Then presently he is working as professor at JSS Medical College. Welcome you, sir. I also welcome Dr. Venkatgiri, sir. He was past president of ISA National, and he is president of SORC Anesthesia. I welcome you, sir.
Thank you. Thank you.
Then I welcome my friend Dr. Bala Bhaskar, who is like a backbone for this WIMS Anesthesia Alumni academic group. And as all of you know, he was past editor of Indian Journal of Anesthesia, past president of ISA National, and he was instrumental in getting us the guidelines, ISA-sponsored guidelines for fasting and investigations. I welcome you, Dr. Bala Bhaskar, and I extend welcome to all those who are viewing this within the country and abroad. Also, our students are there in various countries. I welcome you all. Thank you. Over to Jyotsna.
Thank you, sir. Thanks for that warm welcome. Now I request Dr. Harsu, sir, to introduce today's esteemed speaker, sir. Over to you, Harsu, sir.
Okay. Thank you, Dr. Jyotsna, for giving me this very honored and the pleasant job of introducing my colleague, friend, Dr. Balavenkatasubramanian, who is popularly called as Balavenkat, or many of us call him Bala also. The CV runs into several pages and it takes several minutes, but it will be much more than his talk itself. I have somehow, so I just reduce it to very, very important few things. He's a senior consultant and academic director at the Department of Anesthesia at Ganga Hospital and Medical Center at Coimbatore in India. He is born in the family of Sri S. Jagannathan, who is a headmaster, and J. Sundari, and he's happily married to S. Sasikala. He is blessed with 2 daughters, Kavya and Danya. And, he's got a lucky son-in-law, Mr. Gopalakrishnan, who is a chartered accountant by profession. Coming to his international and national assignments, he was a National Governing Council member of ISA during the period from 2019 to 22, and also he was the founder president and the current chairman of AORA in India. And he has played an important role in several of the important roles, I should say, in the World Federation of Society of Anesthesiologists. And he's no way behind as far as the editing work is concerned, because he was associate editor of a Journal of Regional Anaesthesia and Pain Medicine, as well as he was the section editor in our JOACP and in the IJ as well. And he is an extremely good speaker with extraordinarily high skill of oration. He has delivered more than, you'll be amazed to know, that more than 600 national lectures he has delivered, and to top it up with the international lectures as well, more than 47. He has conducted several workshops, and he's a very good organizer, and he was a participant in the World Congress of Anesthesia held at Cape Town, in Buenos Aires, in Hong Kong, he's in Prague, and also he's going to take a big part in the Singapore as well, which is going to come shortly. And regarding his skills, I think you all know he's one of the most popular program of our anesthesiology, that is a GARC, or Ganga Anesthesia Refresher course. He's continuously conducting it from 2015 onwards. And also he's a certified CTLS instructor and the course director of International Trauma also. The knowledge and the skill and this thing is recognized. He has been invited to deliver several of the oration lectures. Some of the important orations that he has delivered, I should say, Dr. Venkatrao Memorial Oration of the ISA, way back in 2014 he delivered, and also G.S. Ambedkar Oration of Mumbai, the Surendran Memorial Oration of Kerala, the Deshpande Memorial of Oration in Pune, RSCP Oration, Panindranath Thota Oration of Andhra Pradesh State, L.J. Chandrasekhar Memorial Oration of Pondicherry, and also the first ever Professor Divekar oration of the Navi Mumbai, as well as the Dr. Deepak Malviya oration of the UP State. I think the list goes on and on. The time prevents me from talking more about that. And also he is awarded with several of the important awards like T.N. Jam Memorial Award also. And Academic Excellence Award was bestowed upon him by the Honorable Health Minister of Tamil Nadu State recently in the year, I think somewhere in about 2017 or 18. And also to top it up, he's a extraordinarily good and a committed Rotarian since 1999, and he was also the president of the Rotary Club of Coimbatore 2013-14 onwards. So he's a multifaceted personality. He's an extremely good friend, and by nature he's a very, very great friend of everybody, and also great academician, highly skilled clinician. It is an extremely pleasant task of me introducing such a great personality. I think I'm indeed lucky to be with you, Dr. Balavenkat. Over to you for the next few minutes for the topic of the today, the spine surgery and anesthesia.
It's indeed a privilege and honor to be introduced by one of the luminaries of anesthesia in this country, Professor Dr. S.S. Harsur, with several feathers in his cap. Also privileged to have amidst us in the audience very learned senior anesthesiologist Dr. Bala Bhaskar, Dr. Venkatagiri, Dr. Srinivas, and I'm really happy to be a part of the 25th session. Thank you very much, Dr. Jyotsna, for giving us all the required details and intricacies to make this meeting a possibility. And I welcome all the participants of this meeting. I'm very happy that we have about 107 people in the audience today. Century is always something which all of us like, because we are a country which follow cricket so closely. And I think on the Silver Jubilee Day, we have hit the century as of now. And I also see some of the international delegates. I see Dahlia Arendsel. I see Dr. Dahlia Arendsel, the president of RASFIL Philippines. I just saw her in the participant list. So good evening to all. I bring to you greetings from Coimbatore. The city now is known for the Isha Yoga Center and Adi Yogi, the largest human bust in the world today. And I'm very happy that we are meeting on this very holy day when several of our friends are celebrating the holy month, the fasting ending. So my wishes to all of them, Eid Mubarak, to all our friends from those who follow the faith. And also today, a very popular Hindu festival of Akshaya Tritiya, where we buy gold, and it's not only making our lockers filled with gold, but more importantly, our minds getting filled with pure thoughts and golden thoughts inside us. Thanks to this academic event, which is done by the Anesthesia Alumni Associate of WIMS Bellary and the Indian Society of Anesthetists, the Bellary chapter. My sincere thanks to all the office bearers of ISA Bellary for giving me this opportunity. I bring to you greetings from Ganga Medical Center and Hospital. Currently, it's a 650-bedded tertiary care referral center for trauma, orthopedics, and also for major spine surgery. I think currently, this is the only institution in the entire Asia which has moved into a group of highly specialized hospital doing spine surgery. It is called as ISOC. ISOC has got 15 hospitals across the world, which possesses academics, research, clinical work, infrastructure, and you need to have all this to move into this ISOC group. And I'm very happy to share that our institution became a part of ISOC group in the year 2017. There are 12 spine surgeons who do only spine procedures, and we have an intraoperative CT, we have a computer navigated surgery, we have a 3D C-arm, all integrated, we have the high-end microscope. So all this put together gives us the possibility to operate right from a foramen magnum decompression until a sacral issue in the spine, whether it is trauma, whether it is tumor, whether it's degenerative spine, or anything acquired or congenital, everything is operated here. On an average, we do close to 8 to 10 scoliosis every week. So it has got a large turnover of scoliosis surgery. So when I was asked to speak on anesthesia for major spine surgery, I decided to take the prototype, which poses the greatest challenge, is that of scoliosis. I took this as a prototype, and when I complete, I'll speak about few other spine surgeries which offer tremendous challenge to us as an anesthesiologist. And I take this opportunity as the national chairman of the Academy of Regional Anaesthesia of India to be a part of the upcoming National Conference of Regional Anaesthesia in Pune. The registrations are open, and it's very important, even in spine surgery, that after we started using regional anesthetic technique in a major spine surgery in the form of erector spinae block, our major spine surgeries, you see the patient smiling at the end of the procedure. To become very powerful in your concepts on regional anesthesia, I welcome you to Pune. And I also take the opportunity to thank all the seniors here. You're part of the Ganga Anesthesia refresher course. And the next year, it is going to be in the month of January between 18 to 21. And the most important aspect of our meeting is we stress on the holistic growth of an anesthesiologist. Apart from academics, we incorporate all the essential ingredients, a conference which focuses on skill development as well as knowledge and as well as the non-academic components to be a holistic professional and a great human being. I take this opportunity to welcome all of you who are present here to two important events happening in this world in a short while from now. One is the World Congress of Regional Anaesthesia in Paris. It's in September 2023, and that's the website where you can register online. And World Congress of Anesthesia in March 2024 in Singapore. And it is important to note that this happens once in 4 years. World Congress of Anesthesia, conducted by the World Federation of Society of Anesthesiologists, is the largest conglomeration of anesthesiologists across the world. So we need to show Indian presence, Indian work in large numbers in the World Congress of Anesthesia in Singapore. When you deal with a major spine procedure, apart from treating the deformity, imagine this young girl who has come with this deformity. Just imagine the amount of psychological trauma that she would have undergone for this disfigurement that has happened to her, and the amount of stress that the parents have to undergo when they have a child like this. It is phenomenal. So scoliosis surgery is not only correction of a structural deformity, it is also correcting the psychological trauma that has been produced in the child. What are the different types of scoliosis? You know that scoliosis is a lateral curvature of the spine. It could be idiopathic, which is true in most of the cases. It can be congenital. It can be paralytic. It can be associated with neurofibromatosis, or it could be a problem with the mesenchymal tissues. So today, actually, we just finished a case of neurofibromatosis with scoliosis. This patient also had an absent corpus callosum, also had a hydrocephalus for which a VP shunt was done, also had cervical instability, which was fixed first, and then subsequently she underwent a scoliosis surgery today. I just wanted to share with you the complexity of major spine surgery, especially scoliosis, also involves other organ systems in the body, and it's very important for us to know. So it becomes very crucial to properly do a preoperative evaluation of this patient. And there are three systems that are involved: the respiratory system, the cardiovascular system, and the neurological system. As an anesthesiologist, we need to know the cardiopulmonary reserve of the patient. And it's also very important, based upon the location of the curve, our challenges are different. For example, if you have the curve involving the cervical region, which is rare, but it happens, then there is a challenge in intubating the patient and ventilating the patient. When the curve happens in the thoracic region, and it's also very important to know when it is with congenital scoliosis and an early onset idiopathic scoliosis, there is not only a deformity of the rib cage, which produces a mechanical disadvantage to breathe, and the tidal volume is not adequate. It also produces a rotation in the vertebral body. And also, you know that the lung parenchyma, the lung tissues, mature and keeps the alveolar unit gets produced until they're 8 years of age after birth. And when this is an early onset scoliosis, there is a problem even in the lung units being formed well. So they have two problems. One is the mechanical disadvantage because of the structural deformity. They are not able to breathe in and breathe out well. And number two, they have a problem with the development of the alveolar units. This results in presence of chronic hypoxemia because of the hypoxic pulmonary vasoconstriction. And this may lead to pulmonary hypertension, and subsequently a right ventricular failure. So the location of the curve is very important as an anesthesiologist. So the minute you see that the curve involves the thoracic region, immediately your mind has to go into the pulmonary reserves. So in lumbar level, that's the least one which we are bothered about, because structurally it does not affect the lung parenchyma. So as I said, age of onset is very crucial, and 70% of scoliosis are idiopathic, and they are divided into early onset, adolescent, and adult scoliosis. So as I said, it's called early onset is divided again into infantile and juvenile. Infantile scoliosis happens less than 4 years. Juvenile happens between 4 to 9 years. Adolescent, it sets in after 10 years, and adult scoliosis after 18 years. And next thing, which is for all the postgraduates, it's very important. This is an exam question on what is Cobb's angle. And even when you're given a case, when you present a case, it's important to know the Cobb's angle. So what is Cobb's angle? Cobb's angle gives an idea about how much structural deformity has happened. Until about 40%, what you see is you draw a line. Actually, you draw a line. You see the curvature getting altered here. So from the upper part of that vertebral body, you draw a line perpendicularly, and from the lowermost vertebral body, which is part of the structural scoliosis, you draw the next line. And then you will see the angle that is formed. Here you see, like you draw two perpendicular lines. The angle that is formed is 89 degrees. So normally, surgery is advised when it is more than 40 degrees, and definitely essential when it is above 60 degrees. But the challenge also is very important to know when it crosses the Cobb's angle crosses 80 to 90. Even without seeing the patient, you know that structurally, if it involves the thoracic cavity, there is going to be a respiratory compromise, and it's going to produce a definite challenge to you, including the surgical procedure and subsequently post-operative ventilation. So Cobb's angle is very important. 40 to 60, no issues. Most of the surgeries happen when the curve is more than 40 degrees. But when it goes more than 80, sometimes you see with 100. And when you see with 100, you don't go for an immediate correction. I will show you later. So we go for halotraction, which is like an external fixator, and improve the lung capacity. And then we go for a definitive surgical procedure. So the severity is directly proportional to the Cobb's angle, but also it's important to note with some of the congenital disorders, there is vertebral rotation, and apart from correction, we may have sometimes to go for corpectomy. The minute you have to go for corpectomy, that means removal of the part of the vertebral body. The most important thing that goes into you as an anesthesiologist in the preoperative period when you see the patient is the amount of blood loss that can be there in this patient. So the next one, we go for the etiology. And as I said, it is associated with multiple congenital anomalies. Here is a patient, you see not only the spine deformity, but you see the musculoskeletal deformity. This patient had a cataract and the problems with ophthalmic in the optic nerve and ophthalmic involvement. And this patient is, see, it's a von Recklinghausen's disease or neurofibromatosis and Marfan syndrome. So this is associated with scoliosis. And when you see these patients, you always have to think about endocardial cushion defects. So apart from the respiratory system, it's also important for us to rule out the cardiovascular components in scoliosis. So the pre-anesthetic evaluation is extremely crucial. And as an anesthesiologist, because you know there is decreased chest wall compliance, decreased lung volume, possible pulmonary hypertension, and a right ventricular hypertrophy, a cardiopulmonary reserve evaluation is very, very crucial. And mitral valve prolapse, cardiomyopathy, and congenital heart disease are the next important thing that you need to work up in the pre-anesthetic evaluation. Preoperative neurological status has to be precisely assessed because many of them come with neurological partial neurological deficit. This has to be assessed and documented, and this has to be conversed with the surgical team and the patient attendants of the pre-existing neurological status, and it has to be documented. Some of the important things that you need the minute you see the patient and the patient is fixed for a surgical procedure, as an anesthesiologist, prehabilitation and preoperative optimization is important. In this, the most important thing is increasing the lung capacity. So put them on incentive spirometry. And if there is a component of obstructive pulmonary disease, put them on bronchodilators. If you have motor evoked potential and somatosensory evoked potential monitored intraoperatively, there is no need to explain the wake-up test. But occasionally, some surgeons would want it in spite of the SSCP and MEP, intraoperative wake-up test they will ask. This is something very, very special about major spine surgeries, and all the postgraduates have to know about this test. It is called the Stagnera wake-up test. And it is important that you explain to the patient in the preoperative period that we will give you anesthesia, and during the procedure, we wanted to check the neurological status. So we will come and inside ears, we will tell, please move your legs, and you have to move the legs. This explanation, as in the patient's own language, you need to explain at least once or twice, make the patient understand. And this becomes a problem in small children, but in children above the age of 6 to 7 years, we have always found it easy to explain them and really follow it. And this is something which is something very different, in which that we don't do this in any other form or any other surgical procedure needing anesthesia. And also it's important that you decide about the possible requirement of post-operative ventilation. And so this wake-up test and post-op ventilation and the high dependency unit stay, this counseling has to be done. This makes it very holistic. And the investigations which are very specific, apart from the routine investigations you do, are pulmonary function test to know the restrictive and the obstructive component, an arterial baseline arterial blood gas analysis to know the PO2 and the PCO2, and an echocardiogram. So one important factor, which again, it differs from other patients, are which we follow when the patient has got a hemoglobin of more than 13 grams per cent, and they are in the adolescent scoliosis or adult scoliosis, when they are fit to donate blood. And the minute the surgery is decided, usually there is a time of 2 to 4 weeks when they come back. So during this period, we can allow them to donate. So pre-operative autologous blood donation is something which you can all recommend to your patients, and we can get about 3 to 4 units based on the interval period that is available. 1 unit per week can be taken. So this is a great advantage, that you will give back the patient the same or his own blood. And in the process, we have to put this patient on iron supplements, 30 milligram of elemental iron and folic acid 5 milligram per day in this entire week, for making sure the erythropoiesis which happens also has got the right kind of ingredients to prevent any kind of anemia. And when we use citrate phosphate dextrose adenine solution, you can store them for close to 45 days. And in some cases, you can also use preoperative erythropoietin. And erythropoietin not as a component of autologous pre-donation, but a standalone. In case patients come with a hemoglobin of less than 9 grams, you can really consider putting this patient on preoperative erythropoietin. And this is another thing which is practiced in adult scoliosis, acute normovolumic hemodilution. So on the day of the surgery, before we anesthetize, we remove a unit of blood, and we dilute the intravascular compartment with either a crystalloid or a colloid. So this gives 1 more unit. So you can get up to 4 to 5 units in patients with adult scoliosis with a hemoglobin which is more than 12 grams. So this obviates the need to give blood from other donors. Pre-medication is highly individualized, but most of the time it's important to put them on anti-sialogogues, because these patients are going to be in prone position and there is going to be a lot of saliva that comes out. And this is a very crucial point I would want to make, because if there is so much of secretion, there is a possibility that your endotracheal tube plasters that you apply to that might become loose and accidental extubation can happen. So you have to consider using anti-silogogue. And if you are not deciding to use an anti-silogogue, because it raises the heart rate and also it will increase the rate pressure product, and it will increase a lot of oozing, especially from the skin and the subcutaneous tissue. So if you decide not to use an anti-silogogue, which I do, so you tie up with bandages other than, don't rely only on the plaster. This is a very small point, but I wanted to say, because extubation in a prone position is a disaster. And when these patients have endocardial cushion defects, it's also important to prevent the development of infective endocarditis, and hence endocarditis prophylaxis has to be given. The drug which we use for this is cefuroxime, and also the gram-negative cover with either gentamicin, or you can use one of the drug which is antibiotic of your choice for amikacin or gentamicin for gram-negative organisms. The anesthetic plan, one of the important things we keep in mind is at 0 hours of induction, you start this patient on tranexamic acid, you put this patient on intravenous paracetamol, ramosetron, ondansetron, one of the antiemetics. Dexamethasone is given for 2 reasons. One, as a component of multimodal analgesia, and also as a component of to prevent postoperative nausea, vomiting. Now we go to the next important step. So when you want to use somatosensory evoked potential and motor evoked potential, there is no role of muscle relaxant. So currently, the last few years, the technique of choice has been total intravenous anesthesia and target controlled infusion, with the drugs that are used are propofol, fentanyl, and dexmed. This is something which every anesthesiologist should know, that we are moving towards a much safer anesthetic technique, the target controlled infusion. Thanks to the advent of the TCA pumps in this country, currently 3 of the companies market this. And as an anesthesiologist involved in giving anesthesia for such a major surgical procedure, the common queries which comes to your mind is, can a good surgical plane be achieved and maintained with target controlled infusion? Will neuromonitoring be optimal? And what all I should do to make it optimal? What are the anesthetic management in case of a sudden drop in the neurointegrated monitoring signal? And how long will it take for the patient to be extubated awake? So these are all what is expected in the postoperative period. These are the 5 important points that gets into your mind intraoperatively. I wanted to spend a couple of minutes on target controlled infusion. I just want you to see, this is PK Alaris. We also have got Arcomed pump, which is launched. Bebron also has got it. So I want all of you to read and familiar yourself with the TCA pumps. I also wanted you to see the marking there. So you see CP and the CPT. This is the concentration of the drug in the plasma, and CE is concentration of the drug in the effector organ. And I'm coming to it in a minute. And this is a continuous infusion of tranexamic acid that is going in this infusion pump. We start with 10 milligram per kg per hour of tranexamic acid throughout the surgery we run. And the TCA is based on the pharmacokinetic 3-compartment model. You know that the body is divided into 3 compartments based on the rich vasculars, the vascular supply, the degree of vascular supply. So now, how do we start the TCA pump? We set the target, the propofol, the effect site concentration. We start with 7 to 9 microgram per ml, and we give, additionally, we give opioids, fentanyl. And within about 3 to 5 minutes, there is an equilibrium between the plasma level and the effector level, that is the central nervous system. And once we achieve that, we always monitor this patient with BIS. And the bispectral index that we wanted to achieve is somewhere between 40 to 60. Throughout the procedure, we continuously monitor the BIS. And the BIS is a great indicator of the total intravenous anesthesia and whether we need to increase or decrease it. But the target is to keep the the BIS between 40 to 60. And after 5 minutes, then we decrease the maintenance propofol effect site concentration to 3 to 4 microgram per ml. And what is very important is the pumps that they have new formulas. Like initially it started with Marsh model, Schneider model, the formulas which are available on which it works. So the ones which we use the most is Kataria model for adults and PEDFuser for the children. I want all of you to go through these strategies which have developed in these patients in target controlled infusion. But this has made a huge change in several aspects of the patient care. Number one, we will be able to get the MEP SSCP very well with if you don't use the inhalational agents and you use only propofol with fentanyl and a small dose of dexmedetomidine, which runs in the background. So the MEP is what we consider the most important, which monitors the corticospinal tract. And with after we starting using TCI, the signal drop has been very, very less. But only a caution note, when we use the Marsh formula in the TCI, it gives a lot of bolus doses of propofol, and there is a chance of the signal loss happening because of the hypotension that happens secondary to the bolus dose of propofol. So this we need to keep in mind. And what we do, so until they have put the screws, we maintain a concentration of the CP of around 3 microgram per ml. After that, we completely stop. So this is continuously maintained between 50 to 60. It takes about 45 minutes without any drug given with the current formula for the patient to become awake. So 45 minutes prior to the expected time of the completion of the surgery, we stop all the intravenous anesthetic agent. And here I wanted to mention, preoperatively after positioning the patient prone, we also give 4-quadrant bilateral erector spinae block. This has helped us a lot to decrease the intraoperative requirements of the anesthetic agents. So this is just to show the continuous close monitoring, what we keep doing with our workstation. And you see the zero dial setting. We don't use any inhalational agents. Another important thing is inhalational agents are better not to be given in scoliosis surgery because most of the musculoskeletal disorders can also be associated with malignant hyperthermia. And in the absence of dantrolene sodium, I think it's a great idea to migrate to total intravenous anesthesia and target controlled infusion. And because it's a long procedure and you don't want atelectasis to happen, it's a great idea in all the patients to use the humidifier, HMEF, which has got a filter as well. And intraoperatively, it's a long duration surgery. So one of the most important thing is online warming. I found this hotline fluid warmer as one of the best to do online warming in major scoliosis surgery. And the right side, you see the body warmer. This is an important component of all our major scoliosis surgery. Positioning is really the key in scoliosis surgery and in any spine surgery. One of the most important thing you should see is a free hanging abdomen, and diaphragmatic movement should not be restricted. So multiple types of bolsters and frames are available. And when you position the patient prone, the first and most important thing is the minute you position prone, immediately you have to look at the blood pressure. A lot of patients have hypotension. So our focus, the first focus should be that we monitor the blood pressure immediately of changing to patient to the prone position. The most important things that we, apart from that, is eyes, because anterior ischemic optic neuropathy and posterior ischemic optic neuropathy and blindness are associated with prone positioning, and you need to make sure that you use a proper eye protection. I'm going to come to that. And the other things are the padding, which all of you know, brachial plexus, ulnar nerve, the axillary region, the lateral cutaneous nerve of the thigh. All this has to be taken care of. And finally, the abdominal pressure. But this is a special one which we started procuring it last 5 years. We use this specially made headrest. It's absolutely beautiful. The mouth and the eyes go into the And there is a mirror to see whether once you position the patient prone, you can see in the mirror whether you have done it correctly. So this is how it looks. See, now it's all ready. You also see how we have fixed the plasters. The eye is protected very well. And we keep the headrest like this. So the eyes and the lips are free. And now this is how it looks. Yes. And then we turn the patient prone. So this is a small headrest component which I wanted to tell you, which has decreased many of our woos. Because one of the problems which we used to have in prone position was because 4 to 5 hours, sometimes 6 hours, the lips become very edematous, and sometimes they develop, the lips also get injured, and it produces a scar. Lip injury is a deadly thing in young girls who came for a scoliosis correction, and we cannot give a scar in the lip. And this is something which we have had several instances, and we have felt very bad. After which we devised this headrest. And after this headrest came in, our incidence, it has not disappeared, but our incidence of soft tissue lip injury has become very less. And most of the times it is always thought this blindness is because of the pressure on the eyeball. The answer is no. The answer is more because of hypoperfusion and because of the acute anemia which develops intraoperatively because of sudden massive blood loss, most commonly associated with corpectomies. And hence, posterior ischemic optic neuropathy and anterior ischemic optic neuropathy of this, the most important thing which happens because of the posterior ischemic optic neuropathy because of hyperperfusion and acute anemia. And if you see the fundus, fundus will be normal. So it is important for anesthesiologists to know these two components. And as I said, it's very important to see the abdomen should be hanging. Otherwise, what happens, the diaphragm splinting happens. There is a lot of positive intra-abdominal pressure. And this is conveyed to the epidural plexus, and there is enormous amount of oozing. So this anesthesiologist has to really look into it, because otherwise they will suffer because of massive intraoperative blood loss. In the monitoring, it's important all the patients we go for intra-arterial pressure monitoring, especially when we do with TCI. So intra-arterial pressure monitoring is mandatory, continuous monitoring of saturation, end-tidal carbon dioxide, core temperature, ECG, monitoring the urine output, and the specialized monitoring. So this is how we look. And what is the blood pressure map that you would like to? In all this scoliosis surgery, to maintain the cord perfusion, we keep the mean arterial pressure between 60 to 65. And as I said, BIS between 40 to 60. These are two important things which you need to continuously look into. And also the hypothermia to be prevented. So you have to keep a close watch on the temperature. A quick note about SSCP and MEP. We rely more on motor evoked potential. So this is how we keep the transcutaneous, we stimulate the motor cortex. So here we put the electrodes, and then now we receive it. So we put it in the upper limb, we put it in the thenar eminence. So when the cortex, the motor cortex is stimulated, you see the contraction in the thenar eminence. So this is before we actually start the surgical procedure, the baseline latency and amplitude of this waveform is got. The next one, electrode, we put on quadriceps, adductor pollicis, and extensor hallucis longus. And this is how the monitor looks. And if you see, this is the amplitude. And actually, you would see this is the small latency. And what happens is, when does the neurophysiologist tell us if there is an increase in latency by 10% or fall in the amplitude by 50%, immediately they give a call to us, say that there is something going wrong and we need to look into it. This is how our theater looks. Say this is an intraoperative CT. Here is the BIS monitor. Here is the arterial transducer, and this is our workstation, and the monitor. So this is how our theater looks when this is the one which is we use for the computer-assisted navigation surgery, the one with yellow that you see there. So this one is the computer-assisted navigation surgery, which helps you to put the screws appropriately. And this is the the 3D C-arm. These are all integrated together. This is the operating microscope. So this is our typical scoliosis surgery spine theta. Sometimes apart from posterior resection, they go for anterior also, and sometimes a thoracotomy is done. In this case, you have to also be very sure about the postoperative need for intercostal drainage. Quickly, to decrease the intraoperative blood loss, it's important that skin subcutaneous tissue itself, we will lose 250 to 300 ml. So as a routine, apart from tranexamic acid, we also infiltrate with lignocaine with adrenaline, not only for analgesia, but also to produce vasoconstriction and decrease the blood loss. So we also use in major procedures where you expect more than 1.5 liters blood loss, or in a pediatric, more than 50% of the blood volume, we go for cell savers. We have two cell savers available with us. And the extubation protocol will purely depend upon the tidal volume and the consciousness of the patient. Believe me, after using target controlled infusion along with bilateral 4-quadrant erector spinae block, we have got excellent results. Whether 6-hour surgery or 7-hour surgery, it doesn't really matter. One important thing that we have to do as an anesthetist is after 3 hours, if the surgery is progressing, prolonging, we also have to give a repeat antibiotic dose, because hospital acquired infection and surgical site infection will become more the time the surgical site is exposed to the atmosphere. And next is a close watch on the blood loss and replacement. Postoperatively, we look at we increase the pulmonary lung capacity by in-situ spirometry. One of the important things is meteorism, it is called as. Spine surgeries are associated with adynamic ileus. So we need to look into when you go for postoperative rounds, before starting this patient on liquids and semi-solids, always look for the bowel sounds. Also, we have seen a lot of these patients get into hyponatremia and hypomagnesemia in the post-op period, which needs to be corrected. And the most important thing I wanted to emphasize, all of you who are doing spine surgeries would strongly recommend to go for pre-operative, post-induction, prior to incision, the erector spinae block. A simple block, C1 do 1 block, has completely changed the postoperative pain scores of our patients. And apart from this, we also go for multimodal analgesia. All the patients will give paracetamol. They will get ketorolac. So 1 paracetamol, non-steroidal anti-inflammatory, erector spinae block, and if needed, we either go for a dexmet infusion or fentanyl infusion in the postoperative period. But after we started using erector spinae block, the requirement of opioids or dexmedetomidine has become extremely less. But multimodal analgesia is very important. As I told you, when you deal with severe deformities, where the Cobb's angle is more than this patient, Cobb's angle was more than 110. Now, how to improve their lung capacity? So what you see is called the halopelvic traction, and they keep rotating the screw here, and slowly we correct the rigidity of the spine, and by this the compliance of the lung is improved. After about 6 to 8 weeks, we reassess the pulmonary capacity and we find them fit, then we go ahead with the definitive surgical procedure. So this is a great challenging surgery, but it is extremely useful for us to follow certain steps intraoperatively, establish protocols so that they all become very smooth. We also do a lot of tumor surgeries and also a lot of fractures. And one of the most important things in all these patients that we need to keep in mind is one is the blood loss, and second important thing is when you do with tumor, to decrease the blood loss, to go for preoperative therapeutic embolization. So this is just one example of a vertebral hemangioma subjected to preoperative embolization, after which you see the picture in the right, the whole the lush of blood has disappeared, and this patient's the whole vertebral body is removed, a cage is put, and the spine is fixed. So this is a case that we just did today, the hemangioma. This is a fresh from the oven. So this was the hemangioma involving the lumbar vertebral body. So initially we did a fixation from the posterior side, and after therapeutic embolization, first we stabilized posteriorly, and today we went anteriorly through an intra-abdominal retroperitoneal approach to fix the spine. And another important condition which comes to us is very significantly old patient, geriatric patient with severe osteoporosis coming with a vertebral body fracture with development of pseudoarthrosis. And all that the surgeon wanted is to put cement into the vertebral body. The pain relief is instantaneous. And in patients, geriatric patient, we have started doing this with bilateral ESP block as the sole anesthetic agent, and has remarkable results especially in geriatric patients. So other major cases are tuberculous spine, whether acquired or because of, kyphosis, either acquired or because of tuberculosis. And when it involves the thoracolumbar region, one thing you need to keep in mind, when it has produced tuberculosis of the spine, it also can affect the adrenal glands. So it is important to think that the cortisol production may be less. And as an anesthesiologist, we need to keep this in mind. Unexplained hypotension in tuberculous spine could be because of hypocortism, and we need to start supplementing it from the day zero. So spine surgeries offer tremendous amount of challenge to anesthesiologists, but all of them can be met with a lot of ease when we establish definitive protocols, work them preoperatively with optimization and proper intraoperative care and excellent postoperative care. We can make sure that these small children who had come with so much of psychological trauma, you straighten their back, make them a human being who loves themselves and feel very happy. And many of the girls, before marriage, they wanted to get the scoliosis correction done. And we have found that they're extremely grateful for correcting their deformity. And as an anesthesiologist, it's not only important to give anesthesia, but also make sure there's excellent pain relief in the postoperative period, because this is indeed a painful surgery. Sincere thanks for the opportunity. And I hope I tried to cover as much as I could in this allotted time. And I would be happy to answer to questions on some of the points which possibly you wanted more answers. Thank you so much for the opportunity.
Thank you, sir. That was an excellent lecture indeed, which covered most of the doubts and all. So now I request Dr. Gurudat sir to go ahead with the question answers.
So before Dr. Gurudat asks me a question, he should tell the audience how to remain young throughout life.
So be with the youngsters. Definitely you will definitely can be a looking young and also feeling young. Okay, sir. It was an excellent lecture as usual, and you made scoliosis, anesthesia for scoliosis, a very simple one, though it's quite complicated, of course. But everything was in detail you have dealt with. Of course, there are some questions on the chat box. So Dr. Venkatgiri has asked regarding the minimal hemoglobin level for autologous blood transfusion.
Sir, we anything more than 12, we take them, because in Indian population, 12 is the gold standard. So anything more than 12, we subject them to autologous transfusion. And next week, like for example, 4 weeks are there. First unit we take, put them on iron supplement folic acid, repeat the test. If it's more than 12, again take 1 unit. If it comes less than 12, we stop taking.
Okay, sir. Another question from Dr. Harsor regarding infective endocarditis prophylaxis. Is it really required, or
no? It is only. It is only.
Patients?
No, sir. It is only for patients, especially congenital scoliosis, who have also got endocardial cushion defects like mitral valve prolapse, valvular abnormalities. So only in these patients, not for all the scoliosis.
No,
mostly in congenital scoliosis.
Yeah, the 2008 guidelines say actually that only oropharyngeal, in dental procedures where the mucosa is incised. Only such surgeries
True, sir.
prophylaxis is required. Otherwise,
But what happens, sir? The endotracheal tube in prone position, no, sir, and many times you see oral ulcers in them. It is getting breached. So this gives an opportunity for a possible the microorganisms getting into the bloodstream. So especially 6 to 7 hours surgery, this is one small challenge. So we made it as a protocol that we give it to all these patients, only those with endocardial cushion defects, not for all scoliosis.
Okay, sir. One more question is, have you had any postoperative blindness in any other?
So fortunately, not so far, but we have heard, because being a referral center, we have heard anesthesiologists calling from several units to ask about blindness. But since we, I think since we do more cases and we are very rigid in the protocols, and that is possibly one reason that in spite of doing more number of cases, I think fortunately we have not, but lip ulcerations, lip cicatrization, yes, we have had. And accidental extubation we have had once. It was so deadly. And that too, it happened when we were doing an operative spine course when an international surgeon was operating. So we had this happen at that time, and we have to go for a, it was, you can understand what would have been our heart rate. But fortunately, we were able to intubate that patient, turning the patient slightly lateral without abandoning the surgical procedure. So the surgeon didn't even know this happened. But this was something which has happened to us. But fortunately, as of today, no blindness.
No, because I think it's a real nightmare for any anesthesiologist to lose the airway control in prone posture, intraoperatively. And
that too in prone position, sir.
That is what is there. So one more question is regarding the CT, intraoperative CT. What sterilization methods that will be used, and how about the anesthesiologist, where he'll be standing while CT is being done?
Sir, we have a lead apron and a thyroid guard. So, but actually, when we there are a few minutes when we use the CT. Rays are phenomenal. That is one. We have actually got a LED screen. I think that picture also had it. You go and stand behind that, and it has got a small window through which you can monitor the multi-parameter monitor, and all the others are sent out. And we also are highly protected, sir.
Okay. One more thing is echocardiography done preoperatively for all scoliosis cases?
Sir, whenever it is involving congenital, infantile, or idiopathic scoliosis, which happens before the age of 10 years, because sometimes you don't know whether it's idiopathic or congenital, whether there are other deformities that are present. So these patients, I think we invariably subject them to an echocardiogram also, to detect any other abnormalities. But in adolescent idiopathic scoliosis and adult scoliosis, it is definitely not needed.
And one more question is regarding lung optimization. How much before the surgery it should be done?
So the day they see the patient and they decide that this patient has to undergo a correction, usually it's very difficult for the parents to accept immediately. So in general, many of them take a month to 2 months for them to prepare, both for the cost that is involved and also mentally to get the child prepared for the surgical procedure. So the minute the surgery is decided, they are immediately sent to the pre-anesthetic clinic. And in the pre-anesthetic clinic, we also have a dietitian, we have a physiotherapist, we have a psychologist available in the clinic. So all the three work together on giving the dietary habits, on the incentive spirometry, and also the physical therapy that is needed to enhance their muscle mass. All this is done the day we decide to go for surgery.
There is one question from Kirby from Philippines, actually regarding the intraoperative ventilatory settings. So regarding the PEEP, tidal volume, and IE ratio, respiratory rate. So how are you going to set the intraoperative ventilator settings?
So actually, majority of the time, so like for example, the one which you see on the screen now, deformities like this, the lung is extremely small and stiff. And in these conditions, the challenge will be you have to see the minute you intubate, you also have to see the airway pressures. And the best way to do is smaller tidal volumes, increase the rate, and PEEP we keep at around 5. The maximum PEEP we keep around 5. But the logic is to go for smaller tidal volume, and IE ratio we really don't change. But the rate is more, tidal volume is lesser tidal volume, a PEEP of 5. And now you see the level of oxygenation that happens, and then you decide whether you need to alter it a bit. And now most of the times, as I said, sir, we are not using muscle relaxant. And when MEP and SSCP is monitored and when we use a target controlled infusion, the whole thing is maintained with the intravenous anesthetic agent. And in a way, it's very good because the amount of sarcomeres that are present in the muscle mass is very less. So when you give a muscle relaxant, to get them out of the muscle relaxant sometimes becomes a big issue. And that may be the single most important reason why you want to ventilate them post-op. So after using TCI, this is another problem that has been solved.
What about the mode, whether pressure control mode or volume control mode?
So most of the time we go for volume control mode, but in severe deformities, when we think it's inadequate, we switch over to pressure control mode.
So fluid management.
Yeah, intraoperative fluid management. This is another very important question. Primarily, few things that we need to keep in mind. Patient is in prone position. Surgical duration is very long. And if you give plenty of crystalloids, it's going to be physiological dependent edema that happens. So this is a very important component where you need to consider one surgery where you need to consider using colloid, either starch or gelatin, one of them to maintain the intravascular volume, and blood for blood to make sure that you continuously maintain the hematocrit. This is important because, especially in children, suddenly when the periosteal stripping happens, there is a massive blood loss and an acute anemia happens intra-op. So the close monitoring on the blood loss, the surgical step that is being done, continuously calculating the blood that is being lost, and maintaining the intravascular volume with colloid. And crystalloids, if it's given, it's like just the maintenance crystalloids of roughly about 2 to 3 ml per kg body weight. The only issue here is the surgical site is very huge. So there is a lot of heat loss which is happening from the body, which also takes away insensible water loss that happens. And that's why it's very, very also important to make sure that you keep them pretty warm and to prevent both the hypothermia and the coagulation that can happen because of the prolonged surgery, which will again increase the bleeding. So primarily wanted to tell it's a composition of colloid, blood, and with minimal crystalloids.
So what is the maximum amount of blood loss you expect? Around 1 to 2 liters?
It actually purely depends upon the number of segments involved, sir. That is number one. Then number two, whether they are going to do, for example, the child that you see here, they will also go for a good correction. They will also have a costectomy, rib resection will happen. And sometimes they also go for when the vertebral body is rotated, which commonly happens with Duchenne muscular dystrophies. So when the vertebral body osteotomy is done, then the blood loss is huge. But if not, we have tried to keep the blood loss roughly around 600 ml to 800 ml in normal scoliosis. But when you're going to think that this patient is having to going the corpectomy and costectomy, we will go for preoperatively, we decide, and we go for cell savers. So the blood is conserved, sir, and reinfused to the patient.
So,
But
routinely
in general, most of it's about 600 to 800 ml, but it can go up to 1.5 to 2 liters.
routinely you are using intraoperative cell salvage and
intraoperative cell salvage is based upon the type of case we have. So as I said, if we expect a blood loss of more than 1.5 liters, we do it as a planned thing right from the beginning.
so there are a lot of questions regarding use of ketamine, intraoperatively infusion, ketamine, lignocaine infusion to, and along with, whatever the other things you have shown, opioids, metomedine.
So sir, we have established a standard protocol and we don't find any problem with the protocol that we are using. So that's why TCI propofol, fentanyl, and additional dexmedetomidine, we are extremely happy with this, both in terms of blood loss and also since we are continuously monitoring the depth of anesthesia. So we have not ventured in literature. There is ketamine, there is lignocaine, everything has been used. And but for me, I don't want to speak on something which I have not done or have not used.
What about intrathecal morphine? Because one of the questions is intrathecal morphine for these patients.
Sir, actually,
incision.
I'm the concern. What I would actually think is, it all looks very good, like intrathecal morphine, because duration of analgesia will be very good. But I'm not sure how many surgeons will agree. When you're dealing with the spine procedure, there can be a dural rent and you're talking about putting something inside. So we need to think if it is going to be our child, whether we will put intrathecal morphine or whether you will go for a continuous infusion. I have never done this and I really don't want to comment anything of using this, but I would strongly recommend bilateral 4-quadrant bilateral erector spinae block, much more simpler, much more easier, and if you add dexamethasone to this facial plane block, it prolongs the duration of surgical analgesia for close to 18 to 22 hours, sir. So I will strongly recommend this rather than going for an intrathecal morphine.
So somebody has asked about erector spinae block, when you are going to give, whether pre-op
sir, yes, sir. It is done after induction, patient put in prone position, and you assess the level, for example, T2 to L2 if they want to do. So the first injection is given at the level of T4 on either side. Then the next one will be given at the level of T10 on either side. So what happens, the drug spreads in the facial plane so nicely that all the segments are covered. And we need at least about 8 to 10 ml per injection. So it's close to 35 to 40 ml that will happen. And so we go for a diluted concentration and we use ropivacaine as the drug of choice because of its more cardiostability when used in larger volume. So 0.2% ropine is a good choice.
How difficult to do erector spinae block in a scoliotic patient?
The only thing is you should be able to identify the transverse process. And repeatedly when you see, and sometimes it is difficult in the sense when there is a rotation of the body, it is going to be really difficult. But most of the times the transverse process are seen. It's slightly rotated, slightly different, but you can still, most of the time you can make it out, sir.
How do you intubate? Someone has asked. So are you using succinylcholine or
no relaxant, sir? No relaxant.
No, for intubation, sir.
Intubation also no relaxant, sir.
Okay.
So everything is done with intravenous because, as I said, the minute you use choline, you have one more problem bringing in. Because as I said, many of these patients can be prone for malignant hyperthermia. Initially, we were thinking that India is devoid of malignant hyperthermia, but now we know that it's not as uncommon as it could be. That's number one. Then number two, once you give scoline, you never know what is the level of the pseudocholinesterase that is present. And we are wanting to monitor MEP in these patients. Immediately after putting prone, we wanted to see the first MEP. So we don't want to make anything cumbersome, sir. So we never use a muscle relaxant. Everything is with only propofol and just an IV induction with fentanyl. That's it. And we go with that.
So one more question is already I think you have answered regarding combined spinal with GA.
No, sir, I don't. Sir, the problem, the one more thing I will tell about combined spinal with GA for this patients. Like one is intraoperative monitoring that is happening, that motor evoked potential and sensory, somatosensory evoked potential that are happening. I'm not sure what will happen to this monitoring when you completely block, and we will not be able to monitor the quadriceps contraction, the most important things that is happening. So when you want to do MEP SSCP, number one, it's out of question. Number two, even if you are not doing it, the Stagnara wake-up test that you want to do, if you don't have MEP SSCP, can never be performed if you give spinal. And lastly, at the end of the surgery, when you ask the patient to move after extubation, the first thing the surgeon wanted to know is whether the patient is moving both the lower limbs. And because of your spinal, if it happens, what's going to happen? So I think these are all things which we shouldn't even keep in our thought process.
So how many patients actually required post-op mechanical ventilation, sir, in your
again, sir, what I consider the most important thing is analgesia. If your analgesia is very good, then the extubation is immediate, sir.
immediate
On table. So this is the most important factor. That's why I think ESP, I'm emphasizing again and again and again, because we have got rich benefits out of using this block routinely now.
And one question is regarding TCI setup. How are you going to set up the TCI pump?
So the TCI pump, as I said, we have 3 different companies. We have Bebron, we have BD Alaris PK, and we have Arcomed, which was recently launched. So first you have to choose which formula you're going to use. As I said, in the adults, we use Kataria model, and for the pediatric less than 20 kgs, we use the Ped Fuser. You have to log into it, and you have to put the body weight of the patient, and you have to set up what is the CP concentration that you want initially. And within 5 minutes, when CP equals to CE, then you decrease the CP. And as I said, you start with about 8 to 9 microgram per minute, which you come down to about 3 to 4.
I think still a lot of questions are there in the chat box. I don't know whether I'll have to ask Dr. Bala Bhaskar, should we go on asking all these questions to Dr. Balavenkat, or
we will just I mean, it's Dr. Balavenkat's response. So, because everybody is sticking, like we had around 170 people and 155 people are still there.
Sir, for me, no problem, sir. It looks like I'm attending my MD postgraduate, I mean, interview. I mean, not interview, the final exit exam, practical exam. But I'm happy to answer whatever I know, whatever we do. I can definitely share. If the time is there, whatever Bala Bhaskar sir says, it's fine.
Probably, sir, by 8:30 you can close, sir. It's 8:18 now. Just 10 minutes from now, sir.
Yeah, for me, no problem, sir.
Good, sir. You are free. Sir.
Yeah. One question is regarding why you want to avoid muscle relaxants. I think you already answered that.
Yeah.
Another thing is role of anesthetist in post-op rehabilitation.
Sir, only day before yesterday, I gave a talk, anesthesiologist as perioperative physician. Since 2002, we have weaned off all the physicians from the hospital. So it's only surgeons and anesthesiologists, not only the scoliosis patient, every single patient whom we anesthetize, we look after the patient postoperatively, whether it is diarrhea or constipation, whether he is having a cough, fever, antibiotic policy, electrolyte imbalance, arrhythmia, everything is managed by the anesthesiologist. We have a panel of consult super specialists. We do call them when it goes beyond us, because currently it's a 650-bedded hospital with patients coming with multiple comorbid, but 90 to 95% of their medical issues are managed by anesthetists. And that's the reason why our surgeons also have given a very, very free hand. And I also wanted to tell we are 84 anesthesiologists, and even in the night, 14 anesthesiologists are on call, looking after the high dependency unit, the ICU. There are 3 consultant level anesthetists available in the hospital, even in the night, because we operate close to 125 surgeries per day. And there are several complications which happen in the immediate post-op. So it's just not doing surgery. It's so important to look into all the complications and treat them immediately. So we have established this protocol, and it's been running smoothly. And we also, because we receive a lot of trauma, we need this many anesthesiologists also to resuscitate the trauma patients, take them for emergency surgeries, emergency laparotomies, and also EFAST and POC. Everything is done by anesthetists, sir. You don't call a radiologist in a blunt trauma abdomen. Anesthetist does the fast, and then if there is any internal injury, we take them for laparotomy. So entire process of post-op rehabilitation in our hospital for every single surgical procedure is with anesthesiologist.
Did you have any child with right heart failure posted for scoliosis surgery? Because, restrictive lung disease, pulmonary hypertension, so right heart failure, hypertrophy, and failure.
Yes, sir. Actually, yeah, if they come with that, they're usually with severe deformity. That is one, and it should have started very early in life, before the alveolar units are really formed. And the mortality is very, very, very high in these patients when they've gone in for severe pulmonary hypertension. And when pulmonary pressures are more than 60, 65, it's a warning sign for you to go ahead. So these are the patients where we go for conservative method like halopelvic traction. We apply to try to make the rigidity less, put them on physical therapy. And in case if their hypoxic level becomes better, we may consider. But definitely this is a huge challenge, sir. But thanks to what is happening in India now, initially we used to get, when we started, this is my 27th year in Ganga Hospital. So when initially I started, we used to get cases like that. But now I think people are very well informed. They come to us very, very early in their life, so that it becomes easy to treat them.
Suddenly, if there is intraoperative abnormal SSCPs or MEPs.
Yeah. So, this is.
Do you consider any anesthetic problems, or directly you think that it's because of the surgical problems?
Sir, actually, this is a very important question. It happens, especially either you've suddenly deepened your level of anesthesia. This is what has not happened after we started using TCI. This is what the benefit of using continuous BIS monitoring, that not because of your anesthetic agent, it happens. That is number one. Number two, this can happen with acute anemia and acute hypotension secondary to bleeding. So these two things you are closely monitoring. That's why I said we always go for intra-arterial monitoring for all these patients. So we never rely on NIBP. So all these patients are on intra-arterial pressure monitoring to detect the changes faster and continuously monitoring the blood loss and replacement. This is all from the anesthetic side. From the surgical side, it mainly happens when they put the screws, when they put the rod on either side, when they're trying to correct. That is when this happens. So we have to closely watch on that. When that happens, there is a cord stretching. There can be ischemia to the cord. So immediately they have to loosen the screws, loosen it. So it happens. It definitely happens, especially when you deal with severe deformities. And that's why this monitoring is so helpful. So most of the time, it is because you have established standard protocols. You don't see because of the other reasons. Most of the time, it is due to surgical reasons.
Any role for deliberate hypotensive anesthesia technique?
So now, initially, when we never used to use TCI and dexmedetomidine, we used to use nitroprusside, nitroglycerin. It is all has become historical, sir. Now it is so easy to maintain your map with just propofol, fentanyl, and lovely drug is dexmedetomidine. So you can really maintain your pressures very well with that. We don't use it anymore, sir. I don't even remember using the last decade.
So one more question regarding pulmonary artery cannulation.
Not needed, sir. Not needed, sir. I don't think it is going to offer any great benefit. One of the questions which people repeatedly ask me is the chances of developing venous embolism in these patients. But with the volumes of cases that we have done, we have not encountered even a single case of venous air embolism happening. And we routinely continuously monitor the arterial pressure, and we have never ventured into going to more invasive procedures in these patients.
Any role of TEE?
Sir, I will not say no, but actually there is no need, sir. As I said, when you standardize all your protocols, the other gadgets becomes not so important, because you don't see any major changes happening in the myocardial activity. You have such an excellent, with Dexmed, sir, your heart rate is around 70, 75. Your pressures, mean arterial pressure around 65. And if you maintain this throughout, it's enough, sir.
So there is one question. This is, can you elaborate on venous excess in detail, including CVP monitoring on PCI management? Please, on venous excess.
Sir, actually, we routinely do not monitor this at all. We don't monitor the CVP at all because, again, I would like to emphasize that in major surgical procedures like this, we are very, very worried about sepsis. And are we going to derive a lot out of what you're going to do is a question that we ask. So that's why even the urinary catheter, arterial line, anything invaded into the body, we try to remove at the earliest, because we are very, very concerned about invading the system, the bloodstream especially. So that's why we keep all those things to minimum, sir. And I don't think they are going to help a lot in giving us information.
So one more question is, how early these patients are mobilized, ambulated?
Most of the time, we ambulate them on the first post-operative day. So immediately after the procedure, half an hour, they're kept in the recovery, which is next to the operating theatre. After that, we shift them to a high dependency unit, which is also under the care of anesthesiologist. And we continue the infusion, either Dexmed or fentanyl and multimodal analgesia, keep a watch on the pressures of the on the temperature, on the paralytic ileus. Next day morning, they start on clear liquids, and we start, the physiotherapist comes and we ambulate them the next day itself.
Next day, any analgesia?
Analgesia is multimodal, sir. As I said, paracetamol, non-steroidal anti-inflammatory drug is a definitive component for all the patients. And the one which we have given, the block with dexamethasone, also closely lasts for about 18 to 22 hours. And apart from this, if we need additionally, in major corrections, we keep them in the HDU for 48 hours because they may need a fentanyl or a Dexmed infusion for not just the first 24 hours, for 48 hours.
So one more question is there in the chat box. Is it the scoliosis is a one-time correction, or again, repeat correction is required for the child as the child grows?
Yeah, actually, initially we initially in very small children, we put growth rod application, and they come for a growth rod removal. And later, sometimes if the scoliosis keeps increasing, we may go for it. But majority of the time, it's one-time surgery.
So any special surgical instruments used while using intra-op CT for spine surgery to prevent artifacts?
No, not really, sir. Because the intraoperative CT is something which you scan it once and the images are stored. That is integrated to the computer navigated procedure. So it's not that you are using it every second or every minute. It is just the first time that you do, and the images are stored. And no special instruments are required, sir.
Still, a lot of questions are coming.
Intraoperative, arterial is usually radial artery, sir.
Okay,
We go for radial artery cannulation. And ultrasound has made that also very easy.
That's there.
Can ES be repeated? Yes. If the patient is having excruciating pain, you can repeat it after 24 hours. Yes.
Have you had
the only difference, so the only difference of ESP doing later is the plane between the transverse process and the ESP and the spread of the drug is excellent before the surgical incision has been made. But after which it is completely altered. So how will it work? How much will be the spread? You never know. So, but most of the time, when you have done the first 24 hours very well, the rescue analgesics that are needed are definitely less in the after 48 hours. PCA, yes, patient controlled analgesia is another thing which we use. So again, fentanyl or morphine can be used. Again, I wanted to repeat, all this we were using before we made ESP as a component. After ESP, we started using PCA has become less, total opioid use has become very less. So morphine has become less. So I really wanted, if everyone who is listening to the talk will embark on the journey of using ESP for their cases, then they will understand how effective it is that a small intervention can make to the surgical patient.
So we were giving actually regularly the ESP block for spine surgeries, not for actually scoliosis surgeries. Other spine surgeries, excellent pain relief for the patient. Almost nearly 18 to 24 hours of pain relief was there with that.
And also most of the time, they're lying on the incision, sir. That is very important. They're lying on the incision. It's not like abdominal surgery. But in spite of that, they don't have discomfort. That's the beauty of this regional.
Any MH did you come across any time in scoliotic patients? Because it is mentioned in many other books that they are prone for MH. That is the reason you don't use succinylcholine, inhalation anesthetic agents and all those.
Yes, sir. Sir, but we have had one patient with malignant hypothermia. Patient is from, the literature shows musculoskeletal from Kerala. You have to be very careful. All the reported cases of malignant hypothermia in this country, in the literature, all of them belong to Kerala. I don't know why. Venkatagiri has to give the answer, or Venkatagiri has to make available dantrolene throughout the country. One of the two. But we saved the life because we store dantrolene, sir. Even today we have dantrolene. It is not commercially available. So what we do is we buy it from Dubai. It is freely available in the Gulf. And we give a prescription to the patient himself. Patients procure it. And for anybody who wants to know the address where to get dantrolene in Gulf, I can share it. I can share the agent who sells dantrolene in the Gulf. We can procure from him. I can share the number later to Dr. Jyotsna so she can share with the participants.
Yeah.
Dr. Bala, we tried to get the dantrolene, but companies were not coming forward. We tried last year. Yeah, but nobody was coming. Even the DGHS we talked, he also told that yes, we can get it. And he told, show a company to come. If any company comes, two companies, but they thought it is not profitable, how much they were doing a market survey, how much will be the movement and all. They did not come last year. Two companies.
No, sir. Venkatagiri said the problem is not with the company. The problem with the doctors and the clients. They will buy the drug. Who will buy the, suppose if 10 hospitals say that we want, they will buy and give it to us because it's got a short half-life. It's only 1 year. And approximately you need to invest 1 lakh per year. But if you see the number of cases that you do, 1 lakh is nothing. And the life is more important than that 1 lakh. So the problem why companies are not buying it is because if we don't buy from them, they will lose the entire money. And what I would suggest is we can procure it. Now we know how to get it. It's not available in Indian market, but we know how to get it. So those hospitals which are doing a lot of musculoskeletal work should buy dantrolene and keep.
Balavenkat, one of my personal doubt is, we use this ESP block in almost all the spine cases, but not for the scoliosis as such. Do you think is there any difference between a pre-induction ESP block and a post-induction? You said you were using post-induction on the table.
Yeah.
We normally do it in the preoperative room itself before the procedure is started. Our patient is shifted to the OT. Does it make any difference?
Sir, not really, sir, because the soaking time that is needed is only 20 minutes. And after you position them prone, when the patient is anesthetized, if you do the block, it is done so comfortably. Patient doesn't know the prick at all. Exactly. And what is important is by the time they paint and drape and the surgeon comes in to put the incision, already 25-30 minutes are gone. So I don't think there is a big advantage of doing it when the patient is awake in the preoperative room. And doing it in a controlled atmosphere after induction, it's easy to do also, sir, in prone position. In the pre-op, sometimes we do it in lateral position, but here we can do it in the prone position.
We do usually convince the patient then that benefits of the post-operative analgesia. Most of them agree, and we've not had any much problem. But then this is what we practice normally in the preoperative room itself. We give it and then slowly shift the patient to the OT.
Okay.
I think Dr. Balavenkat has answered so much. I think more than the duration of this lecture, the interaction was actually quite prolonged. So thank you very much, sir, for good interaction. I think other questions, I think you can directly answer later, probably. We can contact you directly.
Thank you so much, sir. Thank you.
The dantrolene details you can share with Dr. Jyotsna, sir. We'll
Yes, sir.
Thank you, sir. Sir, we still remain at 1 century, sir. The numbers are still around 132. Yeah. And that shows your popularity. And I wouldn't exaggerate. The other day, I attended your other talk with the role of anesthesiologist as perioperative physician. It was an excellent talk, and they were close to, at one point, like more than 1,500 people who were viewing your talk. So it was an excellent talk. And we are fortunate to have you with us today. Sir, thank you again. And now I request Dr. Parimala to thank the speakers and delegates and everyone. Dr. Parimala.
Yes. Noted.
Here she is, Dr.
Thank you, Jyotsna.
She is our ISA Ballari President.
Okay, thank you, Jyotsna. Good evening, all of you. So it's my pleasant duty to thank our today's well-known and eminent speaker, Dr. Balavenkatasubramanian sir, on today's major topic. It was considerations in major spine surgery. It was a very nice and elaborate talk, sir. I must say it was a great learning as well as the weekend academic feast for not only for the postgraduates, sir, for all the anesthesia colleagues who attended this session. I must say that your real-time images, sir, which were like in various phases, pre-op, intra-op, and post-op phases, and a note on TIVA and PCI, and you're stressing more on the erector spinal block. So all this, like, it's a new learning for us, sir. We try to follow all your suggestions. I must say that this major topic has been made very easy by you, sir. So I thank you wholeheartedly for this and making this session a wonderful one. And I wholeheartedly thank Dr. S.S. Harsu, sir, Senior Professor, for being with us on this academic meet. I thank our Senior Professor, Gurudat, sir, for this for his wonderful moderation in the question answer session. And I also thank our senior faculty, Dr. Srinivaslu, sir, and Venkatagiri, sir, and for being a part of this academic session. My special thanks to all the anesthesia faculty, the regional, national, and the international category, and also the postgraduates of various institutions who are attending today's session. And I thank for making this wonderful, the successful one. And finally, I would like to convey my thanks to the A1 Logics for their uninterrupted and excellent technical support. On behalf of ISA Ballari branch, Karnataka, and the Department of Anesthesia, Ballari. So once again, I thank all of you. Thank you, sir.
Sir, I just wanted to thank you so much, madam. The medicine importer of Dantrol in India, you can note down the number 93. Bala Bhaskar sir can type it also.
Yes, sir. Doing, sir.
93490.
Yes, sir.
73534.
Okay.
So he imports Dantrolene and gives us. He's an Indian, so this can be shared with the delegates.
Yes, I put it in the chat box, and I'll also send through the social media.
Yes, sir.
The participants. Thank you.
Bala Bhaskar sir, thank you so much for the opportunity. Such a pleasure to be a part of your WIMS Ballari. And I think you have done so much to the academics in this country. And this educational event, I think, is another landmark. What you have contributed, your thought process to many of our colleagues. And this, I think, got very enriched by eminent people like Bala Bhaskar sir, apart from you, Dr. Harsur sir and Dr. Gurdat sir, Dr. Venkatagiri, Dr. Srinivas. So it became a very, very nice session. And Gurdat sir, thanks for moderating it so pleasantly.
Thank you.
And thank you, Dr. Jyotsna and Dr. Parmila, for the opportunity for all those who could have watched a movie on a Ramzan day with their family, but they decide to come to watch the scoliosis pictures. I think I need to thank all of them. This all goes to prove that Indian anesthesiologists want to contribute the best, and they wanted to be known very well nationally and internationally. Thanks a lot, sir.
Thank you, sir. Thank you. And it's a 25th event. So that's it's a great coincidence. Like when I spoke to you about this program last month, this became a 25th event. We didn't realize it also. It's a Silver Jubilee program.
Okay, sir.
We are lucky to have you as the presenter for the day. And thanks a lot from our group, sir.
Thank you so much, sir. Thank you. Thank you, sir. Good night, sir.
Thank you. Thank you. Good night, Bhaskar. Good night, Dr. Harsur.